We live? I love it.
Oh, here we go. Now we're live. Hey, welcome. This is the Tech Doc monthly broadcast with Hint, and I'm Dr. Dave.
Dr. Brad.
And welcome. Glad to have you today. We're going to be talking about mental health today. And Dr. Brad and I, we are two DPC docs in Colorado, and we love direct primary care, and we're trying to do whatever we can to help out the movement. And today, we're going to talk a little bit about direct primary care and mental health. And one thing in particular I encourage you to do is to put in the comment section what types of mental health resources that you like. Are there specific apps that you like to recommend to your patients? Are there virtual resources that are helpful? And we're wanting to hear, because there's just two of us so far that are wanting to share what we've got going so far. But if you've got some additional resources, we want to hear it, because this is a community. We feel like Hint is a community. We want to make sure that we are helping each other out. And we're spread out all over the country. And mental health is particularly challenging because sometimes there's not resources for counseling or for psychiatry. And there's disparity across the country. And as many of you know, mental health is the leading cause of disability in adults in the United States. There's increased mortality due to suicide, and it makes it more difficult to manage other health issues. Plus, depression has a major effect on the quality of life for patients, family members, and particularly children. We've seen a significant amount of mental health in our adolescents, particularly because of the pandemic. The pandemic has increased anxiety disorders by 30% over the past 3 years. It's also a huge economic burden. In the United States, $22.8 billion was spent last year on depression treatment. $22.8 billion. And then lost productivity because of depression was another $23 billion, and that was from a few years ago. So anyway, we're just going to be talking about how we do mental health in our practices. Do you want to talk about your practice a little bit, Dr. Brad, about how you manage mental health in your practice?
Sure. Apologies for the Wi-Fi hiccups that I'm having, but hopefully it gets through. My clinic, Strive Direct Health, just in the North Denver area, got a couple locations. Like you said previously, it's a large chunk of what we do, especially post-pandemic, if we can say that now. A lot of our patients, even if they bring it up casually, hey, I'm feeling this way, or hey, do you know anyone I could talk to, or anything like that? It's it's a large part of what we do. I don't know if I have a hard number. I would say at least 50% in our practice we have that discussion. And maybe another of that 50%, maybe 75%, we go down the road, maybe medication or counseling or both. But I actually have found that one of the blessings, if you will, of the pandemic was all the excess. It almost unmasked the anxiety and depression and other mental health concerns, because it allowed people to actually, it's almost changed the stigma, like, hey, you can talk about this. That's been kind of on the front burner, if you will, for a while now, of, hey, let's change the stigma, let's talk about it. But having people bring it up, it's a lot more casual in a conversation. I've had grown men who, I don't go to the doctor. We all have those. I haven't gone to the doctor in 20 years, whatever. And they're opening up. And I think that's one of the really cool things about the pandemic, to where it's like, hey, am I depressed? Is this a clinical diagnosis, or is this something completely different? And so that's one of the joys. I know it's not exactly an answer to your question, but I just started going there, so I apologize, Dr. Day. It's one of the joys of, hey, we're here as DPC docs. You can just text us, hey, I've been feeling this way for a couple weeks, or hey, I had a thought, my sister or my brother mentioned this, what do you think? Or hey, I heard about this counselor or therapist in town, can you vet them for me? Things like that. It's very, very gratifying.
Yeah. When I practiced fee for service, I dreaded it when people would bring up mental health because it took so long.
Not a short discussion.
I had 15 minutes to take care of their hypertension, and if they had hypertension and mental health, I was trained to say, hey, let's schedule another appointment to take care of that. And one of the things I love about direct primary care is like, hey, okay, let's address it right now. And I feel like I enjoy helping people with mental health in my DPC practice. I didn't like it before, but now I feel like we can make a significant impact. It's very professionally rewarding to be able to help people. And one thing, it's interesting because most people get their mental health care from their primary care. There's not enough psychiatrists and counselors to manage all the mental health. 75% of all the mental health prescriptions are from doctors like Dr. Brad and myself. And so we are desperately needed to be able to address the healthcare needs in our country.
Yeah, that's interesting. That's a crazy statistic. I would never, on a multiple choice test, I would not have guessed that high, right? But quick story about one of my patients, actually. I will dehumanize everything for HIPAA reasons. But anyway, she came in, she established with us, and definitely is a high utilizer. She would be deemed as a high utilizer in the insurance world, right? Needs to be seen all the time, things like this. And this individual fits perfectly in the DPC space because they can come in as often as they need to. They can text when they need something. And she has a psychiatrist on some treatment that's outside the scope of primary care, maybe that 25%, right, outside the scope. But having us quarterback it for her, I mean, we've had meetings, myself and the other doctor, we've had visits with her and her therapist and her psychiatrist all in one room, which is just shocking, right? I mean, that's not common, and we love it because she feels like she is getting the care she wants, and the trauma that she's experienced from the system over the past decade is slowly healing. And that, like you said, professionally rewarding, very selfishly put. I love that. I love. So I welcome the high utilizers, the ones that are deemed that in the fee-for-service world, because that's what DPC can do. Is, hey, we're here as much as you need us, and then you end up not really needing us that much over the course of X number of days, months, years. And mental health fits that bill perfectly, to where you need a lot of work up front, maybe a little bit more work down the road, maybe you need a lot of work the whole time. It's very flexible, and that you almost learn with your patient, right? You get to know them so well that you know the nuances. I love that. Anyway, talked way too much again.
Well, I think you raised a really good point about utilization, because many patients that have anxiety, depression also have other symptoms. You mentioned somatization. Many people have headaches, upset stomach, pelvic pain, back pains that are magnified or exacerbated because of their mental health. And their $4.8 billion of unnecessary ER visits could have been avoided had adequate mental health services been given to these patients. And so a lot of times, I think one of the benefits that we have is that we can manage patients virtually after hours. And if we tell all of our patients, if you have any thought about going to the urgent care or emergency room, call us first. And I remember, I logged them, and I found about 9 out of 10 times I was able to prevent those unnecessary visits. Nice. And for employers that are self-insured, those are expensive bills that they're getting hit with that are unnecessary. It's just another plug to think about adding DPC to your benefit plan, because then you get doctors like us and the thousands of the direct primary care doctors across the country that we keep our cell phones on 24/7 to be able to manage and take care of the people when they need it. And they don't need to go to the emergency room, and the emergency room doesn't do mental health particularly well.
That's true. And that ties perfectly into what you said, the open of, it allows that relationship to be built to where they can open up, right? And they can, and then the cost is lower, the spend is lower. I love how many stats you have, by the way. This is so, I'm gonna let everyone know, he just knows these off the top of his head. He did not look these up previously. This is just what Dr.
ChatGPT really helps.
No, right. Actually, side note, I just discovered ChatGPT makes great meal plans for diabetics. If you say, hey, I need a 1 week meal plan for I'm diabetic and I need a shopping list, it'll come up with it. It's amazing. Anyway, not a plug for AI.
And when do they actually order those grocery lists, those items, and have them delivered to your door?
I know. 10 minutes later, it's in your fridge. Yeah, that's a little weird, but yeah. Anyway, how do you do it? How do you do mental? What is your approach to your practice of mental health in your world?
Yeah, I like the USPSTF guidelines. They've updated their guidelines for depression and anxiety screening, and so in the past, before they made the update, it was recommended to do screening only if you have the supports to adequately address mental health issues. But that's now gone. So it's now recommended to do screening for all patients over 18, including pregnant patients. The one thing they don't say is the frequency. It's grade B evidence.
What is that?
So it's a little bit tricky. I'm still trying to figure out, how do I know how often to do it? And do I screen patients every visit, or do I screen them once a year when they come in? But what about the people that don't come in every time? So I don't have an answer for that. If you have an answer for that, please post it on the comments. I'd love to hear how you do screening. Anxiety was a little bit different. The updated guidelines, they recommend screening for 18 to 64-year-olds with the GAD-7 or with another anxiety screening. But there's insufficient evidence for 65 and over. So I just thought that was interesting. So we screen with PHQ-2s and GAD-7s, and I've picked up some anxiety and depression disorders that I think I wouldn't have picked up. And I like the fact that with DPC, I've got time to be able to do those screenings.
Yeah.
And so we've worked that into workflow. And I think that is particularly helpful so that we can be able to identify it before someone ends up with an unnecessary emergency room visit or something. We got a question here.
Ooh, let's hear it.
All right. You got that one, Dr. Brad?
Sure. So I actually posted a video on our social media about I got a 3-month supply, 100-day supply of Lexapro for, I think it was $2.50 or something. Saved the patient a ton of money. And so stocking them, I know this is not exactly the question, but stocking them can be a real value add for a lot of patients, right? For anyone who falls in the gray area where they're uninsured, or anyone who doesn't want to go pay $20 a month for their pharmacy, it's a lot less expensive. So stocking them can be quite a value add in the states that you can dispense out of your office, obviously. But being able to titrate them as needed is one of the key factors for access and compliance. I would say this, correct me if I'm wrong, Kaylee, the underlying question is, or the underlying answer is, the relationship that I have with my patients and Dr. Schuster on the other side of this wall is, we can follow up with them. And Dr. Dave, like you're saying, you have the time to, hey, we're going to follow up in a week. I'm just going to give you a quick phone call, right? See how you're doing after we started this medication, or 2 weeks, or, hey, we just bumped up your dose, or we tweaked something, we added, took away, you tried some lifestyle modifications. It allows, so maybe carrying the common medications is not the main point here. Yes, that does increase access and compliance, but also having that direct relationship to where either I can be the accountability person for that individual, or they can reach out like, hey, I'm way more anxious on this medication, whereas they would have had to wait 6 weeks to get an appointment. That's what I find the most beneficial to for compliance reasons. I don't know. What are your thoughts?
I think this is a great question, because compliance is a major issue. So over 50% of the prescriptions are not either filled or taken correctly, and I think that we can make a big impact on that by how our frequent touch points. So we can have them start a medicine and then follow up with a quick text through our secure texting, through a phone call, and say, hey, are you having any side effects? Are you having, and then, I know that with teenagers, there's the black box warning for SSRIs. I follow them really close. I follow them weekly until they're a couple months out, just to be on the safe side because of that black box warning. I don't see too much of that suicidal ideation that the black box warning is for, but it's nice to be able to have the frequent touch. I tend to use the frequent text more often than the phone call, just because it's usually really quick. I'm like, hey, having any side effects or any problems with the medicines? Is it working? And then they'll give me the message back. And then I'll say, okay, sounds good. We'll touch base next week. That seems to work pretty well for us. Or sometimes we titrate up and down through text.
Yeah. Once you get to know the patient. I had someone who texted me just randomly, not one of our patients, who said, hey, can I go up on my antidepressant? I'm like, well, first of all, I don't know you at all. So let's meet in person first and get to know you a little bit. But I guess they felt they were drinking the DPC Kool-Aid right off the website. Yeah, they understood the assignment. Yeah. Cool. That's a great question.
Hey, Dr. Brad, what mental health conditions do you typically manage, and what do you typically refer?
That is a moving target, isn't it?
I think that's open-ended question. Do with it as you wish.
Yeah, a rolled ankle. No, I'm just kidding. So yeah, I mean, anxiety, depression. That we're primary care in general, but us here at Strive as well. I mean, we're almost the gatekeepers of the screening, like you mentioned. If it's a new diagnosis, or if it's an existing diagnosis and they're already on a medication or some treatment plan, that's bread and butter primary care, right? We have a couple, if there's any suspicion for referral purposes, if there's any suspicion of something, like a mania presents itself, or some type of bipolar, or even antisocial or anything like that, where it's like, or a split personality, it's like, hey, I just want to get confirmation of this diagnosis, that my clinical intuition, my spidey senses are going off, so I will reach out to a psychiatrist, the ones that we're on first name basis pretty much, and just run that person by them and say, yeah, that would be, I'd like to see them first, maybe start them on something. So maybe a little bit more of the down the diagnosis tree, if you will, that might require a little bit more of a heavy hitter medication. But at the same time, usually it's in conjunction with that psychiatrist down the road once I've met with them a couple of times, and we can help manage and tweak the treatment plan going on. So, and again, that comes with experience. I mean, the more you see it, the more you're comfortable with it, if you will.
It's interesting. I was asked to participate in filling out this request for proposal from an employer that was thinking about adding a direct primary care benefit. And one of the questions was, does your primary care offer mental health services? And I was totally shocked. I mean, to me, that's such a no-brainer. I mean, it's like a third of my practice. And one of the things, the stats, and I think that this was probably written, because someone just didn't know, or they just assumed, made an assumption. But 20 to 30% of all primary care visits are for mental health issues, and I don't know if a lot of people know that. And if you look at lifetime prevalence for depression, it's roughly 13%, but there's some studies are as high as 20%. I don't quite believe that. But anxiety is a little higher at 18%. So this is a significant number of patients. And just with those two alone, it keeps my practice pretty busy. Like you, I get worried when people have more significant mental health, and I like to utilize my colleagues, which raises a good question: is how do we find the additional resources? And by the way, if there's other medical people, please put in the chat especially if you have national resources, virtual, that you can share with the rest of us. What resources you like, what apps, what virtual mental health resources you utilize, and why. That would be really helpful to add to the chat. But how does referral work in your practice, Dr. Brett?
Yeah, I mean, as you well know, in the Denver area, a good or any psychiatrist, MD or DO, they're hard to come by. I mean, it's very difficult to find one that you can get in with in a month or two. And that's not unique to that specialty. So obviously, like I was saying before, we have some that we know just through the years of working, and so we can text or call them directly and say, hey, here's the case, this is the individual, would you like to see them sooner rather than later? And then they can usually back channel it on their end to get things moving sooner. In terms of therapists and counselors, there's a great network where we're at to where we can basically screen the patient, say, hey, this is what you actually might be a fit with this counselor or therapist, right? There's some of them that have different areas of emphasis, childhood trauma or eating disorders or body dysmorphic disorders, things like that. And so if the patient is kind of guiding us towards that in the discussion, like, hey, this individual you might be worth talking to. You can screen and vet them on your own. We trust them. If they're a good fit, it could be a good adjunct to your therapy. So referring out to obviously other physicians is one thing, but also matching, almost playing matchmaker. I hate thinking of it that way, but finding the right person that will do the best by that patient is also, I take that very seriously because I protect my patients. I'm very protective of all my patients. I don't just send them to anybody, on a drop-down menu. So do you have a decent network down where you're at?
Well, I was just going to say that one of our employers offers a Sondermind benefit, SONDERMIND, Sondermind. And I think they get like 6 free visits.
Nice.
And then after that, then it's a discounted rate. But one thing I do like about it is the app or the platform. So when a patient is interested in counseling, they get asked a series of questions. And so do they prefer a specific gender, all the demographics of the counselor, the type of specialty in counseling, and then there'll be a list that will pop up of different counselors with their bios so that the patient can be able to identify and pick one and schedule. And I found that there's been a pretty good rate of success the first time. And I find that when my patients try to find a counselor just in the community, just picking up, the phone or, looking online, oftentimes they're not always successful the first time. So I've had success, and that's all online. I know they do have some psychiatric services as well. I don't believe that this employer pays for that, so the patient will have to pay for that cash. And I do believe that Sondermind also does retail. I also have some patients that have a Teladoc or Amwell or LifeHealth, one of the benefits through one of the standard telemedicine companies. And many of those companies, I know Teladoc the best, that they do have counselors and psychiatry, so people can purchase those benefits and to be able to do online therapy that way.
You bring up a really good point also. A lot of employers have these benefits, for the lack of a better term, with Sondermind or similar, that are kind of buried in the long list. I mean, we've all been employees before where you look at that and you're like, I have no idea what all of this stuff means, right? And the mental health, quote unquote, benefit is being pretty widely accepted nowadays. And so if any, that's what I tell a lot of patients, hey, ask your employer if there's any mental health benefits, even if it's meeting with an on-site counselor. Sometimes someone is better than no one to talk to. But also, it's pretty, I'm in a networking group. I don't know if you're in any of these. I love meeting all the different small business owners in the area. They have great stories. I could listen to their stories all day. For some reason, the HVAC companies have awesome stories. Maybe that was my calling in a previous life, was being an HVAC guy. But there was an insurance agent, and she gave a presentation a month or so ago, and she actually said life insurance policies now come with 6 to 12 counseling sessions for free. They'll just cover it for you. And I thought that was pretty cool. It's something you, like life insurance, you sign up for, and you hope you never have to pull up that file on your computer ever again, But that's, again, it's kind of like buried. Like there's different things, like there's ways to get help, if for the lack of a better term, paid for, or it's already paid for, by an employer or a life insurance policy, for crying out loud. I thought maybe other people realized this, but that was just not on my radar. I didn't know that was a thing. So I started poking around, seeing what else, like, employers or, other things like that. So they're there, and it's definitely, and that's what I encourage my patients to do, is like, hey, look around, because you probably have a benefit nearby that you could get it for free, for no money out of your pocket. So
it is somewhat morbid that a life insurance company has had actuaries probably run that and realize that there's an ROI on that.
I know. I didn't want to think of it that way. I wanted to think of it as they were, maybe I'm just too optimistic. If they really want to change the world, I'm just thinking of it that way. Don't jade me, Dr. Dave. Yeah.
Hey, someone was also mentioning that Psychology Today has a therapist finder. And so for people that want in-person counseling nearby, how to find one, Psychology Today therapist finder. You just put that in your search, and it will come up with a list of all the people that are near you and their websites, so you can be able to research. I think that was a pretty interesting way of finding an in-person counselor.
A zip code. That's cool.
Yeah.
In person's hard to come by, especially they're starting to come out of the pandemic virtual world, but in person is hard.
No, my wife, she's a mental health counselor, and she was on that card. Hey, it's got to be in person.
How did you not open with that?
What's that?
How did you not open with that? You've held that from us for 26 minutes that you're married to one.
Well, I just think that most of the time I need most of her attention. So
it's a great network to have, Dr. Dave. Like,
yeah. Well, I must say that I think for her, pre-pandemic, she had never done any virtual, and she's now starting to do more and more virtual, and I think she's coming around to get used to it. And I think the general public, the acceptance of doing virtual therapy the acceptance is there. More people are willing to do online, just because that's what we've done for the last 3 years.
Yeah. It's definitely becoming more normal.
Yeah. Hey, what do you think about these apps? These apps for stress, meditation, anxiety, insomnia?
I enjoy them personally.
Yeah.
I think I always poke around and explore and see what's out there. Headspace or anything like that. I think they're a tool in the tool belt. One more thing to. It's a non-pharmacologic approach. We have a lot of patients where we're at that want to try something non-pharmacologic first, and so we have another tool of these apps. Like, hey, download it, give it a shot. We'll go along with you. We'll do it with you if you'd like. I think they're great.
Okay.
What do you think?
No, I've got a lot of patients that like Calm and Headspace. I think those are the two that my patients seem to utilize the most. I've also heard the mindfulness app. People like that as well. Yeah. There's also some apps that do some cognitive behavioral therapy. Like they go through kind of the process of evaluating your thoughts, challenging the thoughts, and replacing them with healthier thinking patterns. And I think some patients have found that has been helpful. I think most of my patients need to have somebody helping them. I don't think apps alone have been big of a driver. I think most of the time it's the specifics of individual social life, psychological life, health, their body health has required someone to help really formulate a specific plan for them. So I don't know. I think that's just another tool in the tool belt to do some of that stuff. But I think I don't know about you. Do you prefer, or do your patients prefer the more live person or more with apps?
I think generally a broad sweeping statement, they prefer someone in person. But again, if you can only be seen once a month or once every other week, then having the app on hand helps as well. Looks like someone in the chat mentioned Sleep Cove. I'll have to look that one up. I haven't tried that one.
Okay.
But yeah, so I think in person or virtual with a human is always a little bit better. But again, that's also just a tool in the tool belt, maybe just one that is more from the tool belt.
Yeah. And one of my colleagues, she's a specialty in eating disorder, Dr. Workman, and she was recommending an app. It's called Recovery Record. And so it helps patients to keep their treatment on track and timely. So it keeps them on track with their plan. So I'd never heard of that one before, but for those of you that are doing eating disorder, that was a good resource.
Yeah. Nice. I was actually, don't laugh, this is a little bit of a tangent, but that's just the way my brain works. I was catching up on The Mandalorian recently, right? On Disney Plus, not a plug for them, good show. But there's the whole, there was the scene, I don't remember exactly where it was, but there was a droid interviewing a human, right? And I was like, this is so weird. This is a little bit odd. But then it was like a mental health screening. Like the basis of it was, how are you feeling? Do you have any thought? All these things like that. And this machine was asking the human, I was like, we're probably not that far off, unfortunately, to where that could, it was a little bit, I chuckled, and then I chuckled again, realizing, wow, that's actually, that could happen soon. But again, like you said, personally, and our patients, they prefer a human instead of a droid. So
yeah. So are we going to get a virtual counselor pretty soon? A virtual AI counselor?
Yeah.
I don't know. Does anybody know? Is there a virtual AI counselor available yet? That's
a good question.
But you know what? I mean, with what the next version of ChatGPT or the GPT-4 already improving over 3, it's going to be just, I don't know, a matter of probably months, if not maybe a couple of years before I think something like that would be available.
Yeah. So we'll see if it'll be driven by if people appreciate it and like it or not.
So. Okay. So do you think we're going to be replaced by computers and robots?
No, because people want people, right? The robots are going to be a great adjunct to make everything more efficient, like the diabetic meal plan with the shopping list, Yeah. But I think humans will want to talk and connect with humans is what it's going to come down to.
Yeah. Right. People don't care how much you know until they know how much you care, right? It's all about that personal touch.
You just came up with that on the spot again.
No.
Like, I don't know how you do it.
My parents told me about that years ago.
And you remembered what they said? Impressive.
I do, yeah. I listen to my parents, don't you?
Oh, yeah, of course. They're probably listening right now, honestly. They're quite supportive. So.
Hey, well, I know we're at time. Any last parting thoughts, Dr. Brad?
Mental health is a pandemic, an epidemic. I mean, it is very prevalent. And so DPC is the way to go, obviously. And being able to be there for patients is very rewarding. Patients love it as well. So find a DPC doc. If you're not one, or if you're a patient, you need one, find one. It's the way of the future. More than AI.
That's right. Yeah. Hey, well, thank you everybody for joining us today. This has been fun. Great topic. This is Mental Health Awareness Month, and I'm really glad we got to talk about this, and hope you have a great rest of your day.